enter the room.
Hello, I'm Dr. Jayshree. I'm one of the doctors in the neonatal unit. And may I know your name, please?
My name is Alison, doctor.
Oh,
I want to know what's happening. I mean, my child is lying there in the incubator in her own poo. What is this? Is that how you actually run your hospital?
oh. Hello, hello, Miss Alison Cole. I know it's a tough time. It's a difficult time for you to be away from your child, and that also for around 5 days. So it's perfectly understandable that you are a bit upset, and you have gone through a lot. But you see
I'm
now.
not upset because I was away from my child. I'm upset because when I went and saw my child, she was in filth. That's unacceptable, doctor.
Oh, so sorry that you are feeling like that, but you see now the baby has to be kept in an incubator because the child was born around 27 weeks. That is a premature delivery. So it will be better that the child is kept inside and with minimum uh, interference as far as possible. That is what is happening.
I don't understand. Okay, I was already told that when she was taken away from me and put into an incubator. First thing I was told was that there is a risk of infection if she's a premature baby. And on top of that, when I come and see her, she's in filth. Nobody's there to even clean her. Is that something that you're not even trying to explain me what has happened?
Oh, sorry to hear that about that. But you see, we have this in the here we have kept everything as far as possible. The sterile surrounding, the babies in a sterile area, and the babies on own poo and all that will not bring any infection to your child. So please don't get upset at because of that. And
What are you saying, doctor? You're talking about all sterile and everything. When I go there, I can literally smell things. Are you saying that that is sterile? Are you saying that if my child poos, if she should just be left in that filth? There's nobody to even clean her. Are you justifying that to me?
I'm sorry that you're feeling like that, Ms. Cole, but you see, they will be cleaning at particular intervals, and we should not open the incubator like all the time. There are only fixed times that we are allowed to do that. Otherwise, we'll be introducing infections, and the child is premature, so the baby is susceptible to all types of bacteria. And inside there is the baby's own poo and urine will not cause any infection to the baby. But if we clean it more often by opening that incubator, then there are chances that there will be infection which we introduce. So that is what we call iatrogenic. We don't want that to happen, right? And I'm sure that you also don't want it to happen. Am I right?
Exactly. I do not want it to happen. I feel you're just throwing words at me to confuse me at this point. In fact, are you telling me that a child should not be changed from her diaper
No,
if she soils it? Is that something that you tell all new mothers? This is my first child, and if you're trying to brainwash me with your words, I'm sorry. I'm not falling for that.
not at all, not at all. It's not at all like that. You see, we have babies' good well-being in our minds, and you know that ours is one of the best neonatal units here, and we take maximum care to give protection to a child. But the thing is that what you see now, it is not like we will be changing at frequent intervals, not like when you see we change. It's not like that. So there are particular intervals which we are allowed to enter and clean it, because otherwise if we just do whenever the child is peeing or passing a stool, whenever we open and clean, there will be too much infections to be introduced. So now, does that address your concern?
Absolutely not. In fact, you tell me that you have one. How often do you change? I first of all want to know that. It seems like you really don't know much. I want to talk to your senior. I want to talk to somebody who would know something better.
Definitely, definitely. If that is the case, I'll definitely let you speak to my senior, and the senior will be here at any moment, so we will let you talk to him. So, is that okay? Can you wait till that time?
Yes,
Is
I
that,
will, and I want to get to the bottom of this. In fact, I want to make a complaint. This is not something I'm going to let go so easy. This is
uh,
my
uh,
child, doctor.
yeah, it's perfectly understandable. And you see, anytime you can make a complaint because we have facility to do that also. So you can do that anytime. But I think it is better that first of all, can I?
2 minutes remaining.
You were saying, doctor?
Yes. So see, first of all, can I know what happened? Like, so what happened? And you said that this is your firstborn child. So, what happened? Why was the delivery at 27 weeks? Can you just explain that to me?
Yes, I mean, my blood pressure was high. They said I had
Huh.
something eclampsia and they had to deliver the baby immediately. I
Oh,
mean, and then they told me the risk that it would be, the child would be in, and that she had to be in an incubator and they would take good care of her. And that's not something that I'm seeing, not at all.
I'm sorry that you had to undergo a difficult phase during your pregnancy, and it's perfectly understandable that you feel like this. But I hope that you will understand that we have your baby's best interest in our mind. So whatever
I
we
mean,
do in this,
saying all these things, I see there are multiple nurses taking care of my child. I don't even know who is the nurse who's taking care of my child. Why are there so many people? And even after having so many people, I see that she's not been changed. Is that you're not even explaining me why she's not changed?
no, that is what I'm trying to explain because there are nurses and each bed is assigned, each cot is assigned a nurse. So that is why you see a lot of nurses here. And they will go in only at particular time intervals only because they are allowed to do that. Otherwise, they will be, as I explained, the
What are
infections.
you saying, doctor? If something serious happens to my child, the nurses won't even come there until it's dead.
No, definitely, if there is something serious happening, definitely the nurse will go.
Move on to the next station.
Thank you, Dr. Jayashree.
I'm so sorry. This is completely new topic to me.
I completely understand. So basically, what we are trying to simulate is that
Yeah.
there will be a lot of difficult stations like this, and so what they're trying to test in this exam is that if you are NHS doctor on your first day, what all are the different scenarios you can encounter and how professionally you can actually deal with them. So
Okay.
angry patients is one of the very common stations and it's one of the hardest
Yeah.
because even in the exam, the simulator will be screaming at you, they'll be shouting at you. You have to maintain your calm, you have to address their concerns. And I'm sorry if I was little, little too. So that's the same thing that we also encountered in our first exam. We were completely baffled, we were completely thrown off, and we didn't know what we would do at that time. So as you correctly understood, this is an angry patient scenario. And in this case, the main thing about angry patients is they have to acknowledge why they are angry. Justifiable thing from the patient side. Yeah. So it was a very justifiable situation from the the mother side to see her premature child in filth, right, in her own feces, and that is something that is not acceptable because we all know that premature babies are at a higher risk of infection, and I'm sorry. have one more person joining us. Hello. So if any child, or if in that high risk scenario, if they see that there are situations that can cause infection, and nothing is being done about it, that should be immediately addressed. In this case, since the child was not changed, that was not something that is acceptable, especially in a high risk scenario of a premature child. So this is something that you need to acknowledge of for the patient, saying that I'm so sorry, this is absolutely unacceptable, and this is not something that should have happened to you. Because you have to validate their concern, because they're coming with, because literally this is the first time this person has had a baby. She's very concerned. Every single aspect will be, in high super focus. So they will be noticing everything about the child's care. And if they feel that something is out of place, you have to address it and understand their concern and validate it. So, the first thing in this case would be to validate the concern, and then understanding that if a premature child is in that situation, is it acceptable or not? In this case, it is not acceptable because there is a chance of infection, and that is something that you're trying to minimize in a high risk situation like this. So validate that, say that this is something that shouldn't have happened, and I'm so sorry that this has happened. And understand a little bit more about the child. Like, does the child have any other conditions? Do you have any other conditions? How are you doing after your delivery? Right? So initially, when you start off with the consultation, always start with the structure. So the first thing that you need to do would be data gathering, and then address the situation, and then go into management. So the first data gathering questions that you did end up asking eventually. All right, our examiner is also ready. I'll just take 2 minutes, Nivedita. So the first data gathering question that you need to address is what happened? Why did it happen? Right? So the what happened situation would be like, what is the issue that you're with? And why is it that it is a high risk scenario? Because she had a premature child. Why did she have a premature child? You need to understand that. Does the child have any problems? You need to understand that. And do you have any other concern? Is there any other concern? Always do an ICE, which is ICE is a mnemonic that we try to promote in our sessions, which is ideas, concerns, and expectations. So you're not trying to give them information that is not useful for them. You're only giving them information that they are trying to seek. So how do you get that out of them? By doing ICE, which is the idea. What idea do they already have about the standard of care? Concerns. What are your concerns? Like, what are the different aspects of your concerns? And expectation. What do you expect out of us? So we will definitely be making an 8-minute series on how to ideally approach the scenario. We'll send you a link on that. So in the meantime, we have our examiner. Yes, Dr. Nivedita, you can start.
Hello, Dr. Jayashree, and hello, others. It was a really good performance. I just loved how you kept your calm throughout the end. That was very impressive. So you can take it forward especially in these kind of hard stations. So there are a few stations like medical errors and angry patients, which are a bit difficult for us to handle because when we enter the station, the patient just throws the concern on our face. They are like, how can you do this, doctor? And why are you doing this to? What is happening here? So this will be their opening line. So at many times we also forget to do our identity check. Many doctors do forget to, make sure that we're talking to the right person or not. So we should be ready for all these situations. And I just loved how calm you were. So yeah, that's a good thing we need to take from this. And we need to maintain our calm. We need to know what we are doing, and we need to move through the station. So this is a pretty common station, and there are some modifications to it, but this is the whole idea of the station. So the patient is the mother is quite concerned that the baby is covered in poo, and she's worried about infections, and how the doctor comes and empathizes with the mother and tells her that this won't be happening again. So that's the whole idea of the station. Um, and so you started off pretty very well. So you empathized with her and you offered her an apology and you told her. So, and it's a good thing that you confirmed her name and her age, and you asked her why you was, what's happening, how can I help you, what happened morning. You covered all that. That was really good. But we also need to ask, when did you notice this, or how often does this happen? Is this the first time that this happened? How long has she been in this state? So we need to first address the condition. So we need to make sure that was it cleaned, or you should, if it's not clean, we need to tell that, okay, I'll immediately address that. I'll tell someone to clean it. And we need to show that we are taking actions and we are being really involved in that situation. And we need to ask her how she's feeling, because she's going through a lot, right? She's a new mother. She had a delivery 5 days back, and there may be a lot of things going on in her mind. So what they expect us in PLAB to is, we need to be a safe doctor. We need to be someone who understands how the patients feel. So we need to ask her main concerns. As Dr. Ann said, we need to ask about eyes. That's very important. So that's how we can earn marks, right? We know her concern and we'll be answering her concerns, and we'll be scoring marks in data gathering management and in IPS. So eyes is a very important tool that we need to follow for that. And yeah, you asked her about her delivery and her complications, and but we went to that part at when we had just 2 minutes remaining. So I would suggest that we get into data gathering in the first 5 minutes and keep the last 3 or 4 minutes for management. So we can ask about that and we can go through that. So and other family history, allergy history is all just like a formality, and we can do that when we have time, just to know if there's anything. And but her social history is very important, her mood and how are her things going on, what she's facing. That's a really important thing we need to look into. So this is how the station goes. So once she has told all that and she has told her concerns, we need to start. This station is more about like a management station. So you did validate her emotions, which is really good. Um, and we need to tell that this won't happen again. This is not what usually happens in a hospital, and that you're not sure that how this happened. We'll take a look into it. We'll be talking to all the people who are in charge, like with the nurses, the ward managers, anyone involved, and you need to tell that once I'm talking to them, I'll come back to you and I will say what happened. So that's like a promising thing we do, and the patient will, develop more trust with us. So that's what I expect from this whole station. So yeah, we need to also say that in this type of cases, usually the nurses will be working in shifts, and they'll be having some handovers, and there'll be a new nurse who has just come to the shift and she wouldn't have noticed, or things like that. So when we do our data gathering, the patient might say that why are there like different nurses working? I have seen different nurses who have been on shift. So what's happening, and things like that. So we can just explain them, this is how it works here, but we have protocols, and the handovers do happen properly. I'm not sure what happened, so we will look into it. So it's all about like we need to make sure that this doesn't happen again. We need to really sound that to the patient. That's the crux of this whole case. And another thing is, the patient is really angry and they want to make an official complaint. So we need to use the word PALS. So you did mention that yes, you can complain and we'll help you about it, but the word they expect here is PALS. So we need to mention that. That just shows that we know something about how NHS works. We are getting familiar to the system, and we need to tell them, and we need to make sure that we are quite transparent about the process. So when you complain, they will look into the what happened over here, and we'll schedule a meeting, follow-up meeting, and we'll let you know what's happening. We'll be completely honest and transparent about it, and we'll make sure that this doesn't happen again. And another important concern is about the baby. So we should also say that if you note any signs of infection or if we find anything, we will take care of the baby, and we'll do further investigations if needed, and we'll make sure that the baby is quite safe and that this doesn't happen again. And in this case, regarding the IPS, it comes all over the case. So we need to be very empathetic. We need to align with the patient, and we can say that you did do that very really good. I just liked your IPS very much, and you can say that you are very upset about this. I can see you're going through a lot, and in all the angry patients cases, we should never interrupt the patient. We whatever, even if they're taking a lot of time to express their emotions, we just need to give them the time, and we should not be focused on completing the station. That's what many people do. So they focus on completing and telling all the points, and they tend to cut in the patient. So I think that's a really important thing that we shouldn't follow. And you did that really well. That's a really good thing. So we need to let the patient talk, get everything, and then we need to say what we have to say. And as the patient is under a lot of stress, we need to just signpost them and tell them that I would like to ask some questions, and then we can proceed, because the patient's main aim is to shout and let her emotions out. So when we just go in and start asking questions, it doesn't seem like so it's better that we just signpost and then we start our history taking. And we can schedule a follow-up meeting, and we can just say that, because in many of the cases we won't be able to finish it in the 8 minutes time. So it's better if we follow up meeting, like if we set up a meeting, it's like a safe thing we do. So we can say that even if you're not able to complete, I will surely look into the case and I will let you know what's happening. And a lot of reassurance is needed here. So we need to say that we're sorry this happened, and we'll make sure that this doesn't happen again. So that's the whole station about. Do you have any doubts about it, doctor?
Unmute her.
I'm sorry, I think you're muted.
Yeah, Dr. Jayashree, you muted. You'd have to unmute again.
1 second. Yeah. So how can I address this patient? Like the patient is, should I call the patient by first name or last name? What is the?
So, Dr. Nilika, you want to take this? Or?
Yeah, you can say doctor if you want. It's not a thing.
So, Dr. Jayashree, thank you so much for that. That was nice. So, for addressing the patient in UK, the norm is always first name basis.
First
Uh,
name.
yeah, so that's how normally people talk in the UK. Even if it's an elderly person, they call them by the first name. And when you want to show respect, you usually call them by their last name with Mr. or Mrs.
Okay. Okay.
Mostly, most of the stations they expect you to use a first name basis. But if this is an elderly patient, or if you feel like you want to show respect, you can call them by their last name with Mr.
Okay.
Mrs. Cole. Thank you. So you can do that too. They most probably they'll tell you Allison is fine if you try to do that.
Okay. Okay. Right.
So that is one thing. But the way you maintained your composure was really good. But one big mistake that I noticed that you made in this session is that you were trying to justify.
Yeah, that is true.
So
Yeah, I didn't know the situation. I like in ICU, so I was thinking maybe in UK this is the norm because they don't interfere that much, So I was thinking maybe that is the norm.
yeah, yeah, that's something that most of the people do, because when you don't have enough information, we know a lot. We end up saying somehow, but remember the patient only the examiner is only expecting you to know whatever is given in the candidate information, nothing more than that. They will not expect you to know anything more than that, and you don't need to tell anything more than that. So if you think about it, in this case, as soon as before you even enter the station, you have 1 minute 30 seconds to read the station, right? That's how the exam is. So in that 1 minute 30 seconds, you have to make sure you gather as much information from the given stem as possible, the given question. So it's not just that you need to, it's not just the name and age that you need to see here. So you need to formulate your questions before you enter. So you need to formulate your questions. So at this point, you saw this, you saw that it's a baby that delivered 5 days ago, 20 weeks of gestation. So immediately in your mind, the mother might have had a C-section recently or a difficult delivery recently, and she is coming. She's definitely going to be in a upset state. So one question that you should not forget to ask is, how are you doing now? So that will reduce the tension a lot, because when even if they're angry, if you tell them, oh, I'm so sorry, you've had a delivery recently, how are you feeling now, how was the delivery, and the premature status is also something that you need to ask. Why did the delivery happen prematurely? Was there any reason? And how are you feeling before that? So these are a lot of questions that you can gather before you even enter the station. Because till you entered the station, you didn't know that the patient is going to be angry, right? So,
Okay.
Dr. Niveta, you want to say something?
Yeah, another thing I wanted to add is we are not allowed to use medical jargon, that is the medical words. So when we try to explain to the patient also, we need to be as simple as possible. You just use one word, iatrogenic, because we know the meaning of that, but it's just used to us, right? We just tell it by our flow, but we need to make sure that we don't use anything like that. So even for small things, we need to say, like for iota, we can say it's the largest big blood vessel or something, some things like that. So we need to make sure that we are very focused on that, because it just slips out, and but we lose marks for that. So we can just take that into notice.
Okay.
Yeah.
Yeah.
So following up on that, the only time that you're allowed to use medical jargon is when you're telling the diagnosis, right? That's the only time you will have to mention the diagnosis definitely in every station. If there is a diagnosis that you made, you have to tell the name of the diagnosis and the scientific term it is. Then you explain it in simple terms. But rest of the time, do not use any medical jargon. Always try to talk in normal sentences, because there is a section called language, which will mark you based on how the entire station. So that is something very important.
Okay.
And so we'll just go through the station. So this is our workbench. So where basically we have all the cases. So today's case is basically an angry patient. I'm just going to mute you, Dr. Jayashree, if that's okay. There's some noise in the background.
Yeah.
All right. So today is the angry patient. Just give me 1 second. Uh, can everyone hear me? Sorry, just having a little trouble. Yeah. So today is an angry patient. So what we do is we have all the cases. We've divided them into topics. We have 11 topics. So these are all the talking stations that come in the exam. So all the talking stations, there are a lot of cases that can come, and the main thing to know is you need to have a structure for every case before you even as soon as you start the case itself. So you need to understand what the patient is going to be. So for example, in an angry patient, the patient can be angry from the moment that you enter itself, or the patient can be angry after you tell them a news. So there are two different angry patient scenarios where your approach is completely different. So the current one we saw is basically angry from beginning, where the patient is already angry. So you need to keep that in mind when you are approaching this case. So let's see how we can cover the entire station in 8 minutes. So ideally, always start the consultation by confirming the full name and age of the patient. That is very, very important. That's a one mark in that data gathering that they'll definitely mark you on. Because if you don't talk to the patient if you don't find the identity, you don't know who you're talking to, and that might be a big blunder. So always make sure you confirm the name, full name and age, and then move on to the explaining anything. So in this case, as soon as you went in, you noticed that the patient is angry, but you immediately went on to acknowledge the emotion. You said that you seem angry, you seem upset, but you immediately went on to explain her why you think she is angry. Don't do that. Always ask why. May I know what happened that caused you to be upset? So always try to do data gathering in whatever filler words that you're using. For example, I can understand how you feel. So always try to stop it at that in the beginning of the station. Always, because there's a lot of data that you need to gather that will give you more things to say later in the station. So always ask. So you just say, I can see that you were very upset. I'm really sorry to hear about your experience. Can you just tell me what happened this morning? And as soon as she tells you, you ask more. Always remember that the first sentence that the patient gives you will not tell you everything that you need to know for the station. You always have to follow up in the data gathering. So always follow up with an open question. As soon as you ask, tell me what happened. The patient said, I saw my baby completely covered in filth. Like, oh, I'm so sorry to hear that. Can you please elaborate what exactly do you mean? Because filth can be 100 different things. We don't know what that is. So always elaborate. Ask them, "Oh, what exactly happened. When did you notice this?" And you ask them, how long has it been? Because at this point you don't know if this is a mistake. From what you thought that this is not a mistake because this is normal that it happens, but that's not the case, because you don't know how long the baby has been sitting there like that, right? So do not assume these things. So the only thing that you can do is ask more questions. So you just ask, oh, I'm so sorry that happened. So how long was she in that state? And she'll tell you, yeah, I came and it's been there for like 2 hours. I've been seeing her like that. Then what would you say? You can't still justify, right? So always try to, that will tell you the intensity of the scenario, how sorry you need to be. So always ask exactly what happened, and did you inform anyone? Because if she informed someone and still they didn't do anything, that's even a bigger mistake. So always ask that, because that's the immediate thing that they do. They have to inform someone. So after that, once this is done, now you calm. Now at this point, you should try to calm the patient down by saying, "Yes, that's a big mistake. Do not. If you had justified, the patient will continue being angry. All right. So angry from beginning, most of these cases they will become calm once you finish your data gathering. That's usually the case for all the angry from beginning, where you will have a window of data gathering as soon as you finish your initial incident data gathering. So once you find out what exactly happened, then you tell them, you immediately validate. You tell them, yes, absolutely, it's a big mistake, especially knowing that your baby is premature. There's no way that should have happened. I'm so sorry. I'll definitely take this and make sure that I'll investigate and find out what happened. Then the mother will calm down. Then you say that, okay, is it okay if I ask you a few more questions about how you're feeling, or how was the delivery, any complications, and how is the baby doing now? Because you don't know anything yet. You only thing you know is that just 27th week old premature baby in an incubator, and so far the history you've gotten is that being treated badly. Now you need to ask more questions, like why is there anything else that why is the mother so concerned? Was the delivery so bad? What if there was a problem at the delivery? The mother will be even in a even higher tense state, right? They would be even more protective. So always ask what has happened so far, how is the baby doing now, and how are you feeling currently, and then ask ice. So what Dr. Ann said, ice is basically is something that the patient, so if you look at the patient instructions, there's always one section called ideas, concerns, and expectations. So this is something that every simulator will have on their clipboard. So they are waiting for you to ask the question. So what is ideas? Idea is, so you see a patient who comes to a doctor. So why does that happen usually? When they have a problem, they go to a doctor, but that they don't do that for all the problems, right? Like for example, you have a headache, you just take a paracetamol and it goes off and it's fine. But when you go to a doctor with a headache, that means that patient already has an idea in his head. They're thinking something. They already has an idea what could be causing it. So you always ask that first. Is there any particular? So in this case, it's mainly what is particularly making you upset. Why do you think that she will get an infection? Is there any particular reason for that? So that is idea. And concerns are, is there anything else that you're concerned about? Then only she mentioned that the nurses, so every time I come, there is a new nurse. So that is something that's very common for us because we know that, there is shifts and all that. But you can't tell that to the patient. You can't say that, okay, there's one nurse can't look after your baby all day or things like that. So you twist it. Say it in a way that, we make sure that the baby gets 24 hours attention. So we follow this shift system that ensures that the baby is always taken care of, and there's always a nurse available at all times. So that's why whenever the nurses change shift, they do something called a handover, which makes sure that everybody's on the same page. All right. So so we have protocols to ensure that this happens. All right. But you have to tell that there is a concern. You always validate the concern. Say that there is a concern. I can understand that there are different nurses every time, but this is how it works. But we will see if we can do something for you, because you don't know. You're not telling them that, okay, only one nurse will take care of your baby from now on. But you can give them a hope. So maybe that is something that we can arrange, because maybe this is a premature baby. Maybe there is staff, like there is a rotation of nurses that they can arrange, that way that the mothers knows the nurses that they are seeing them. We don't know it, but we can promise them. We can say that, let me see what I can do. I'll talk to the senior and make sure that the nurses, even if they are changing, they are handing over properly. So that gives her some more assurance, right? Then do not let the incident go ever, because whenever that has caused them the anger, you've explained, you've admitted to it that it's a mistake, that it should not have happened. Now tell them what is going to happen now, what you are going to do about it. That is, you always tell them that I will investigate the situation thoroughly. I will speak with the nurses, the ward manager, anyone in your baby's care. I'll make sure why this has happened, and make sure that it won't happen again. All right. Then always promise to report back, because that's the least you can do. Thing is, I'll tell you I'll do the investigation, and I'll tell you what I've come up with. I'll tell you what has happened. I'll tell you what protocols that we put in place to make sure that it doesn't happen again, right? Then you always assure improvement, that you say that this will not happen again. All right, we will make sure that this will not happen again. That is something they just want to hear, right? Then, so by this time you have only 2 minutes left. So if you notice this, you could have nicely asked all the questions. So we've given 30-second sections for each thing. So you can happily cover all the points in that 30 seconds. And if not, you can spill over to the next 30 seconds. So what this does is this runs with the time.
Begin. Enter the room.
Sorry. So this is the time. So as the timer runs, you can put this in front of you, and you can turn on the timer, and this will run in front of you. So this will keep moving as the time moves. So every 30 seconds, you will get a task to do, task to ask. You have a thing to cover in that 30 seconds. And even if you're not covered it, you can go on to the next section, but make sure you have it in your head, right? So that is what we created. Basically, we wanted to find out how we can fit the entire knowledge that we have in our mind about this case into this 8 minutes. So we did this for all the cases, and right now Angry Patient and Breaking Bad News is available to use, and we're working on psychiatry right now. And so this, if you notice, as soon as it moves to the 7 minute mark, it switches to the next section. So this tells you what you should be doing in that 30 seconds, right? Then at the end of it, so and if you keep doing this, and the timer also has colors. So what we do is first 4 minutes we always give it for data gathering, and the next 4 minutes we always give it for management. But the problem is if we don't know the time, we don't see the time at all in the exam, in the real exam. In the real exam, you only get these voice prompts where it says begin and then enter the room, where you enter the room. And then after some time, you'll just hear another bell that says 2 minutes remaining. That means you only have 2 minutes remaining to wrap up your consultation, right? So that is very important because they are telling you like you don't have much time. You have to do your management. That's mainly because of that. A lot of people continue their data gathering till the 2 minute bell, and some of them continue even after that. So the GMC has put the 2 minute bell just to remind people that there is a management that you need to do, right? But the 2 minutes is not enough for management because you have equal marks for data gathering and management. We cannot give 6 minutes for data gathering and 2 minutes for management. So what we did is we made it 4 minutes. So first 4 minutes, if you can maintain an internal clock where every time you ask a few certain number of questions, you have an idea in your head how long has passed, right? That way you know that okay, I need to move on to management. That only comes with practice, right? So always practice by looking at the time and keep a time in your head. So you when you're practicing, you practice it without looking at the time first, but in between keep looking at the timer so that you can calibrate your internal clock with the actual timer there, right? It won't be perfect, but you will get to a stage. The more you practice, you'll get to a stage where you will know exactly when the 2 minute bell is going to ring and you will be ready for that, right? So you would have already finished your data gathering, you would have already started your management. And so what we tell every doctor that takes the mock test is remember 3 points at 2 minute bell. So whenever you hear the 2 minute bell, these three has to ring in your head. That is safety netting, follow up, and leaflets and pamphlets. All right. So safety netting is basically you just have to make sure that after that's all safety netting is, right? All you have to do is, so for example, this mother is preeclampsia, right? And she had a C-section recently. So the safety netting here would be, please make sure if you feel any if you feel any pain or discomfort, or if you feel lightheaded or something, please let any one of us know. And if you feel the baby is not very active, or if the baby is not drinking milk properly, if your baby is not feeding properly, please let us know. So these are very simple steps that you can put in, that even if you are not, or even if the nurses are not taking care of, the patient themselves know what they need to look out for, right? These are called warning signs. So that is safety netting. This is has to be done in all stations, and you will get 1 mark sure if you do that, right? For management. Then the next thing is follow up. So always follow up. This is another an extra step to make sure the patient is not dead, right? That is, you make sure that you see them again. You are sending them to a specialist, let's say, but you don't know what's going to happen, whether the patient is going to the specialist or not. What if he missed the appointment and then don't know what to do? Always set up a follow up with yourself. Even if you send them somewhere, say that I'll see you again in 2 weeks or 3 weeks, or in a few weeks. You just say that in a few weeks I'll see you again, to make sure everything is going well. Make sure what I've the treatment that I've given you is working, or if we need to change something. So that is follow up. You always have to mention that. And the third thing is leaflets and pamphlets, which is just reading material that NHS spends billions of pounds every year on generating, on creating. And that is very, very important, because every single situation in life, like every single disease, every single symptom, every single procedure, they have a leaflet and pamphlet available. So always mention that. I'll give you some reading material, I'll give you some leaflets and pamphlets so you can read more about it, right? So that is something you have to do. So these three, if you remember, you'll easily get two or three in management, because even if you don't know what medication to give, even if you don't know what diagnosis is, you'll always be able to score 2 or 3 marks if you properly safety net. That is, if you send the patient home safely, that's all. If you are sending them home, or if you're sending them somewhere else, you make sure they go there properly. So the timer color that I was saying, so if you see, this is a different color where the management needs to be done. And at the 2-minute mark,
2 minutes remaining.
so you'll hear this audio prompt and you'll see the timer flashing. So that means you only have 2 minutes left, and just remember the 3 things. Can you repeat the 3 things that I said? Sorry, you muted. But yeah, I hope you said safety netting, follow up, and leaflets and pamphlets.
Yeah.
All right. Thank you so much. That was perfect. So now, is there any doubts, anything else that you want to ask me?
In this particular scenario, should we ask about the date of birth also, because this is the mother who has come, right? So should we ask the name we'll ask, and what about the date of birth?
So the age. So if you notice in the station, in the question, they'll most probably give you the age. If they give you the age, you confirm it. Definitely.
It's like almost reading a chart. So two people can have the same name. So what all are the identifiers that are given to you? You need to confirm it to make sure that the person that you're talking to is that person.
Yeah, it's like 2-factor authentication. Basically, it's like getting an OTP where you know the name. You just, if you know the age also, then you are more sure that this is the correct patient. That's all. And anything else? Anybody else has any doubts? Feel
Any
free to ask.
questions? So like Dr. Rohit explained, this is our OSCE workbench, and as of now we have angry patient and breaking bad news loaded. At this point, we since it's in our beta run, we are giving it for £5. But soon this offer will be ending, and we will be loading more cases. And as it goes on, as we load in more cases, we will have to hike up the price.
So as we add more modules, the prices will increase. But if you buy it now, you will have the new modules for free.
You'll get the access to the new modules.
So
at the current price.
yeah, the 50% off sale is ending on 7th of October, and so you will get all these and more. So we will be releasing more over the coming days, and we will get access to all that. And we also have a sale on the mock tests. So this is how we. So you've seen how we conduct the free mock now. So what we do is if you get a paid mock where we conduct these paid mocks privately where nobody else will be there, and we have 3 categories. One is 2 stations, one is 8 stations, and one is 16 stations. So the 2-station one is something that we think is helps a lot, because what we do is you can try 2 stations, you can attempt 2 stations, and we will give you the feedback, and you can do a repeat attempt of the same 2 stations again in the same call. So that helps you so much especially if you're early stage. It will help you so much in building your approach. And so the 2-station mock costs £60, and at this point we are running a 50% off sale, and for people who take the free mock, we give it at 70% off. So that will come to only £18 for the 2-station mock. And the 8-station mock is a single attempt mock where you get 8 cases, and all 8 cases you get very detailed feedback. And one more thing that we have promised is that there is no time limit for the feedback. We will continue to explain however long you need, especially for the paid mocks. And so the 8-station mock costs £100, and with a 50% off, it's £50, and with 70% off, it's £30. So if you do the free mock with us, or if you even book the free mock with us, you are eligible for the 70% off as well.
Thank you for choosing TuringMedSchool. Good luck with your preparation.